Okay, so today we're going to be talking about suctioning your patient along with trach care. So we're going to combine these two skills together, all right? I'm going to discuss three different kinds of suctioning. Ballard suctioning is the closed suctioning that looks like this. Then we're also going to be talking about nasotracheal suctioning and tracheal suctioning, okay? So if someone is unable to clear their secretions effectively on their own by coughing and trying to encourage them to bring them up, a lot of times you may have to suction them. It is a sterile procedure because you're actually going down into their trachea, so you do need to do it as a sterile technique. The other thing about when you're suctioning is you're suctioning out the patient's secretions, but along with that suctioning, you're also pulling out their oxygen. So they're going to desaturate and they're at increased risk for hypoxia, all right? And that's with any one of these suctioning. So for that reason, you're going to have to hyperoxygenate them prior to the procedure because as soon as you start to suction them, again, their O2 saturation level is going to decrease, all right? So again, make sure you're encouraging your patient. They may be very anxious because of this, and just let them know what you're going to be doing. You yourself want to be donning your PPE, gown, mask, goggles, just because there is some chance that you may come into contact with patient secretions. So that is for your own protection. With all three of these different suctionings, you're going to set your wall suction to 80 to 120 for the suctioning. You're going to do an assessment on your patient, including listening to lung sounds prior to. You're going to check their O2 saturation level prior to, and when you're listening to their lung sounds, you're probably going to hear some coarse bronchi. Even without auscultating their lungs, it's very obvious sometimes your patient does need to be suctioned, okay? The other thing with this is when you start to advance that catheter, you're going to hit the patient's carina, and the patient's carina is where the trachea branches into the two bronchus, the right and left bronchus. So whenever you're inserting that catheter and you hit resistance, you don't want to begin suctioning immediately. You want to back up 1 to 2 centimeters before you start to apply the suction. Okay? And again, with all three of these suctions, you don't want to suction on the way down. You only want to suction on the way back out. Okay? So again, I'm going to talk about the closed suctioning first. This is a patient that has an endotracheal tube. They would be hooked up to a ventilator, and the closed suctioning is this suction catheter right here that's enclosed in a plastic sheath, and that usually gets changed every 24 hours. A lot of times respiratory therapy will take care of that, okay? So I really don't have to worry about sterile technique because again the catheter is enclosed in that plastic sheath. I'm going to just put on a pair of clean gloves. Okay. If they're on a ventilator, you would just hyperventilate on the ventilator just by pushing a button. Again, I've already listened to my lung sounds. I've checked my pulse ox. I'm making sure that the O2 sat is up high enough before I begin suctioning. Patient should be in a semi-Fowler's position, okay? And again, just trying to reassure them, let them know, you'll be here with them because again, they may be a little anxious with this procedure, okay? So the one thing you want to do with this is support this endotracheal tube because you don't want to extubate your patient while you're pulling that catheter out. So you're just kind of supporting this T-piece here. Okay, and there's a lock on this catheter. Okay, it should be locked when you're not using it, you can turn it on prior to suctioning. Again, supporting this T-piece here, and you're going to be inserting this catheter through the plastic sheath. Okay, when you hit that carina, you'll meet resistance. Patient usually will start coughing and gagging. Just back up maybe 1 to 2 centimeters before you apply this suction. And there's a black line on here that should be out here. Okay, then your catheter is the whole way out. Okay, so again, you can, if you feel like you need to go down again, you can make up to 3 passes with any one of these suctionings. You should be waiting about a minute in between. Again, I can hyperoxygenate my patient in between, making sure I'm checking the pulse ox, making sure it's up again to a good level before I start again. And again, just pushing. And this is also called Ballard suctioning, until you get down, back up a little bit, and then apply suction on the way out until you pull that black mark clear out of your endotracheal tube. Okay? Then to flush this line, they have these little normal saline bullets here. Okay? Make sure your tube isn't up like that. You don't want that saline to go down into the patient. And while you're squeezing it, you're just applying suction, and then that just clears your suction catheter of all the patient's secretions. Okay? So again, that's Ballard suction or closed suctioning, and that usually goes along with the ET tube, or it could be a trach, but the patient would be on a ventilator. Okay? Just swap this out here. The other two types of suctioning, again, would be nasotracheal, which you're going down into the patient's nares and then into their trachea, or tracheal suctioning. Okay? So I'm going to demonstrate the tracheal suctioning, and then we'll talk about the difference between tracheal and nasotracheal. Okay? So again, you would want to have your PPE on for this one, because if that patient starts coughing, okay, they could actually have some secretions coming out of their trach tube. Okay? So I've checked my doctor's order. I have my PPE on. Come in, assess your patient, listening to lung sounds, checking a pulse ox, okay? And again, just letting your patient know that, if they have a trach, they're not necessarily going to be able to talk, so they may need to just kind of hand signal you if they need you to take a break or whatever, okay? So I have my PPE on. I have my suction set to the 80 to 120 on the wall suction. And with your gloves on, you might want to just test that, make sure your equipment is working properly, okay? Again, I have my pulse ox on. I see that it's a little bit low already, so I'm going to turn my oxygen up here a little bit, try to hyperoxygenate them and get their pulse ox up a little bit more, because I know they're going to desaturate once I start to suction them. Okay? Patient is in a upright position, and I'm going to, once my pulse ox comes up, I'm just going to put this tray collar so that they're still getting a little bit blow by from that. Okay? Also going to drape my patient, okay, and get ready to do my suctioning. I'm going to take these off, wash my hands. Okay, and again, this is a sterile procedure. I'm going to open up my catheter kit. Okay, And what I want to pluck out of there is my box that I'm going to be putting my saline in. So just touching the outside of that. Okay. Checking for initial date and time on here. It's within my 24 hours. I'm going to pour a little bit of my saline into here to flush my catheter. And then I'm going to open up my sterile kit here. Okay, once you have your sterile gloves on, I'm going to get out my suction catheter. And I'm just going to kind of wrap it around this hand to keep it sterile. So my dominant hand is going to be sterile. My other hand is no longer sterile. It's going to connect this to suction. Okay. And the way you apply suction with this is with your thumb, okay, of your unsterile hand. Okay, every time I put my thumb on here, it's going to suction. Okay, so I'm just going to test my equipment here, make sure it's working. Okay, and again, I'm looking at my pulse ox. I've already hyperoxygenated my patient. If I haven't removed my trach collar yet, you can do that with your unsterile hand, okay? And again, you don't want to apply suction on the way down, all right? So I'm keeping my catheter sterile, and I'm advancing into the patient's trachea. Once you hit resistance, and again, your patient will start to gag and cough, back up 1 to 2 centimeters, and then you are intermittently applying suction while you're rotating the catheter on the way out. Okay? Then you can clear your tube with your saline. And I'm going to keep this sterile. I'm going to reapply my oxygen. Again, hyperoxygenate, checking my pulse ox, making sure it's back up to a good level. Okay, if I think I need to go down again, they still sound like they have a lot of secretions. Okay, I'm going to advance this, no suction on the way in, hit the carina, back up 1 to 2 centimeters, and applying suction intermittently on the way out while you're rotating the catheter. And then clearing the tube again. Okay, so I could go down a third time, no more than 3 times at one time, okay? And your suctioning should last no longer than 10 to 15 seconds, okay? All right, so then when you're all done, then you're just balling this up in your glove, okay? And again, making sure your pulse ox is okay, reassessing lung sounds, and turning your oxygen back down to the appropriate level. Okay? So that is through the trachea. If you are doing nasotracheal suctioning, the only difference is you need to use some water-soluble lubricant to insert the catheter through the nares. Okay, so what you would do is while you're pouring the saline into this is before you have your sterile gloves on, while you're pouring the saline into your little cup, you can also spread some lubricant somewhere on your sterile field here, okay, so that you have that all ready to go. All right, then you put on your sterile gloves. Okay, and attaching this. Again, checking your equipment, and then you need to lubricate this the first 1 to 2 inches, okay, so that you can insert this into the patient's nares. Okay. The other difference is, because I'm starting in the nares and not in the trachea, you're going to have to insert this a further distance, usually like 14 to 20 centimeters. But again, you'll meet resistance, back up 1 to 2 centimeters, and suction on your way out intermittently. Okay? So everything else is the same, except you have to lubricate 1 to 2 inches of the catheter for nasotracheal, and you also have to insert a further distance because you're starting in the patient's nares. Okay? All right. So we're going to combine this skill with trach care. The other thing I wanted to mention, if your patient is not already hooked up to an oxygen source like a trach collar and you are going to suction them, you can give them some, couple breaths of oxygen with the ambu bag prior to suctioning to kind of get their O2 sat up and hyperoxygenate them. Okay? All right. So, as far as the trach care, one thing with if your patient has a trach, okay, one thing you should always have at the bedside is one of these obturators, okay? You may see it like taped on the wall, taped on the headboard, okay? The purpose of this obturator is that if this is not secured, the ties are not secured, your patient coughs and coughs out that trach, their stoma is going to close and then they have no airway, okay? So what you can do with this is, if they would cough this out, you put the obturator in there and it lets you reinsert that trach back into their opening there, okay? Or you could also just keep a same size tracheostomy at the bedside, so you could insert that if this would come out, okay? So that would be for emergency purposes. The other thing I wanted to say about this is, when we have you do this skill, there's an outer cannula and then there's an inner cannula, okay? So this inner cannula comes out, okay? We're going to have you clean this and then reinsert the inner cannula into the outer cannula, okay? A lot of places now have disposable inner cannulas, so if that's the case, you are just, with gloves on, taking out the inner cannula, disposing of it, and then reinserting the disposable inner cannula, okay? But we don't have enough of these for everyone, so, and you may still see ones that they have to take out and clean, so we're going to have you do it like that. You also might see a Velcro holder in place of these ties, but we have ties that we're going to be using. Okay? All right, so again, you might want to have on your PPE, just because if you're disturbing that area, your patient might be coughing and you're at risk for coming in contact with some secretions, okay? I've already suctioned my patient through the catheter prior to doing trach care, okay? And again, establish some form of communication with them. Did my respiratory assessment, my pulse ox, and just let them know that I'm going to be doing tracheostomy care on them, okay? You can loosen this, just kind of keep it on blow-by so patient's still getting some oxygen, but again, you don't want that to interfere with the sterility of your procedure, okay? You could use half-strength hydrogen peroxide mixed with normal saline if there's a lot of dried, kind of crusty secretions on the patient, all right? If you would do that, you would just need to rinse it then with normal saline, okay? Your book just has you using normal saline, so that's what we're going to use, okay? So again, I have my patient in an upright position. I have my trach care kit here, which you will need to bring along for your validation, and the suction kit from your bag as well, okay? I'm going to open my sterile kit. I'm going to pluck out these gloves and set these to the side. And then I want to pull out my sterile drape here. And trying just to touch the 1-inch border. Shiny side should go down. And laying down your sterile field. Okay. Then I want to dump the contents of my kit onto my sterile field. And there are 3 compartments in here. Okay, I'm just going to fill 2 compartments with normal saline. One is for cleaning my inner cannula, and the other one is for cleaning the patient's incision, if it would be a newer trach. So again, coming in from the side here, trying not to reach over your sterile field, and filling 2 of those compartments with the saline. Okay, I'm just going to put on some clean gloves right now. And I'm just squeezing these wings here of the patient's inner cannula, okay? The only part you should be touching is this outside here, not this part that's going to be going down into the patient's trachea. And I'm just going to drop that in my normal saline. And then I'm also going to be removing this old dressing here, okay? Note any drainage on the old dressing, color, odor, consistency, amount, and then just kind of assess the patient's incision there, color and drainage from that. Okay, I'm going to remove those. I'm going to wash my hands. And now I'm going to don my sterile gloves. Again, this procedure is sterile mixed with unsterile. So I'm going to call my dominant hand sterile, okay? And my dominant hand is going to be the one that's taking things off of my sterile field, okay? Now that I have my 2 gloves on, you can go ahead and kind of organize these supplies, maybe in the order that you're going to use them, so you can eliminate some of the reaching over. Okay. All right, so first thing I'm going to do is clean that inner cannula. I'm going to grab my brush with my sterile hand. I'm going to grab my inner cannula, okay, going to do this so that I'm not doing it over my sterile field, and I am just cleaning the inside of that, getting rid of all those secretions, and kind of scrub the outside of it as well, and then rinse it again in your normal saline. And I'm just kind of dispose of my used things over here. Okay, once you've cleaned and rinsed that, I'm going to go ahead and again with my sterile hand, I'm going to pick things up off my sterile field, and I'm going to pick up a pipe cleaner, and you're only going to dry the inside of that because I want to leave some saline on the outside to kind of act as a lubrication when I'm reinserting it into the patient's outer cannula. Okay, so I've cleaned and dried the inside. Again, I'm just holding here and this hand staying sterile and reinserting the inner cannula into the outer cannula and making sure that's secure. Okay, the other thing I need to do is clean the patient's incision. So I'm going to pick up a sterile Q-tip into the other compartment of saline. I'm going to switch it to this hand in case I bump the patient's chin or something. And you're going to do only one swipe underneath that faceplate. Okay, and then discard that. Again, another Q-tip in my saline. Switch it over here. And another swipe underneath the faceplate. Another Q-tip, and again, this is where you can use half-strength peroxide and saline if you have a lot of secretions. I'm going to clean the top of this faceplate. And then switch this and clean the bottom of the faceplate there. Okay. Now I don't want to leave that saline on the patient's skin, so I have two 4x4s here. I'm going to switch it here and dry the top underneath the faceplate. Again, just one swipe, and switch it into my unsterile hand, and underneath the faceplate, drying off the skin. Okay. So now that I've done all that, I'm ready to put my new dressing underneath. I'm going to just try to handle it on the edges here and get it up underneath this faceplate. And again, this is where sometimes your patient, because it's very irritating when you're moving that around, they might be coughing and it might be uncomfortable to them. So again, you might want to offer them pain medication before you even begin this procedure. Okay? So once you have that new dressing, the only other thing I need to do is put a new tie on there. Okay? Again, this is where you might see the Velcro tie. If I had another nurse here to help me, I could take off the old tie and have them secure the airway in the patient. Okay? If it's just me by myself, I'm going to leave that old tie in there because I don't want a chance that the patient might cough and then that trach come out and then I not have an airway. So I'm going to leave the old one on until I get the new one in and come over here. And I want to secure this using a square knot, which is right over left, left over right, okay? And the reason for the square knot is that it doesn't loosen up at all, okay? And you just want to make sure you can get at least one finger underneath there. You want it snug but not so tight that it's going to cause skin breakdown, okay? So once you have the new tie securely in place, then you can untie the old tie and remove it. Okay. Again, go ahead and replace the patient's oxygen source, okay? And making sure that their pulse ox is okay and everything is secure there, all right? So things you would want to document regarding your suctioning would be how many passes you had to go down, the secretions, you know, what they look like, the amount, your assessment prior to suctioning, assessment after suctioning, okay? And as far as your trach care, the fact that you did it using sterile technique, your assessment of any drainage on the old dressing, your assessment of the incision, and again, how your patient tolerated the procedure if you had to medicate them for pain. Okay, so then you're just removing these and washing your hands. Any questions at all on the 3 different kinds of suctioning, the Ballard, the nasotracheal, the tracheal, and then the tracheostomy care? Okay.